At the Global Liver Institute, we believe it all starts with a patient. So what happens when a patient, a liver patient no less, one of the 500 million people living with conditions that often go undiagnosed, untreated, or misdiagnosed, mistreated, and stigmatized, brings the challenges of liver patients front and center? And what happens when a patient then leads a discussion with world experts in policy, research, clinical care, and wellness on ways to overcome these challenges? Let's find out today on GLI Live.
All right, hello and welcome. I am not Donna Cryer. I am privileged to be able to be asked to step into the host chair for GLI Live this week while Donna is unable to join us. I am the NASH Programs Director for the Global Liver Institute, lovingly known as GLI. Now, NASH, advanced fatty liver disease, if you will, is on the rise worldwide. Prevention, treatment, and support demand a global response, and there are many tools that we have available today to stop NASH now. Now, the Global Liver Institute conducts International NASH Day each year on the second Thursday in June. This is the 5th or 6th annual International NASH Day coming up right now. And to celebrate NASH Day, GLI is hosting 4 virtual panels featuring international experts, leading physicians, and advocates who will share the latest insights on how to confront and mitigate this dangerous disease, while partners around the world will be hosting grassroots events such as educational events, screening events to combat NASH, tailored to the needs and resources of each community. This year, we have 17 medical society endorsements. I think that's as of yesterday and counting, and numerous partners from across the globe. So for this week on this episode of GLI Live, we are joined by Dr. Jonathan Stine of Penn State University and Dr. Amy Goss of University of Alabama Birmingham to share their expertise on NASH in relation to physical activity and nutrition, respectively. I want to thank you guys both for joining us. Welcome. And by means of introduction, instead of just kind of having you guys say what it is you do, let's set it up a little bit. We know that in NASH right now, there's not really a pharmaceutical a drug treatment that's been approved to help treat NASH or even reverse NAFLD in NASH. And lifestyle changes remain a mainstay for clinical care for most affected patients. Now, can each of you share a little bit about kind of what you do, who you are, what your research area is, and why it is so important to the global movement around fatty liver disease and NASH? Dr. Goss, why don't you kick us off?
Sure. So I'm Amy Goss, and I'm an assistant professor in the Department of Nutrition Sciences at the University of Alabama at Birmingham. I've done a lot of diet interventions and controlled feeding studies looking at the effects of nutrition on chronic metabolic diseases. Those include obesity, type 2 diabetes, and also non-alcoholic fatty liver disease. So one of my major research efforts right now is trying to identify a dietary strategy that would be most effective at reversing non-alcoholic fatty liver disease in kids. So we have feeding studies going on. We're really trying to look at not only reversing fatty liver disease in a pediatric population, but also the way in which that can affect health long-term in these kids. Does it affect other metabolic processes like insulin sensitivity? Does it improve improve the likelihood that they won't develop other metabolic diseases down the road, such as type 2 diabetes? So a lot of our research efforts are trying to look at really diet quality and diet composition and advanced clinical care in a sense that we can sort of help shape recommendations for pediatrics and adolescents with NAFLD.
Dr. Stine.
Yeah, so first and foremost, Jeff, I want to thank you for stepping in, and a huge gratitude on my part being here with you and on Donna's request and to be on this panel with Dr. Goss, and she's doing some incredible research, and you can't have dietary change without the backside, which is physical activity and exercise. So as you pointed out, there's no cure, there's no approved drug therapy at this time. So, working on dietary change and increasing physical activity, it really is the best thing we have to, combat this, leading cause of liver disease worldwide. So, our research group has said, we know that most people with NAFLD and NASH are physically inactive, right? Less than 20% are going to meet the required amounts of activity according to their healthcare providers. So we asked why. Why do people not perform activity? And asking this question, we found that education from healthcare providers, lack of time, lack of fitness resources, and pain to be the biggest barriers. So, keeping these barriers in mind, our research group is working on designing and developing novel, individualized exercise prescriptions to allow our patients with NAFLD and NASH to be successful. Because if you do support people, you put them in the right environment, they are going to become physically active. They're going to meet their weight loss goals. They're going to make healthy, tangible changes to their lives, and hopefully, put the brakes on this process, if not even, reverse fatty liver disease.
Amy, I want to talk a little bit more about your study on the adolescent diet and NAFLD and its implications for families. You mentioned the phrase diet quality in your introduction just now. Can you talk a little bit about the study and about what you mean by diet quality?
Sure. Yeah. So our most recently funded NIH study, we wanted to look at the effects of a moderately carbohydrate restricted diet versus a fat restricted diet, kind of with the idea that, nothing too extreme, but a low glycemic diet that's moderately restricted in carbohydrates may affect the liver metabolism in a way that helps sort of deplete the lipids stored in the liver. So we know that improvement in diet quality does help fatty liver, regardless of the macronutrient distribution of the diet, right? So both diets that we're testing are high quality, right? They're low in added sugar, a lot of whole foods. We're just simply manipulating that macronutrient distribution. So when we think of poor diet quality, that kind of goes hand in hand with like having really highly processed foods, really high glycemic, added sugars, things like that. So those diets that we're testing, both are going to be quote unquote high quality diets. But we're kind of asking the question of whether we slightly lower the carbohydrates, increase the fat content, if over an 12-week period, we're going to feed the entire family groceries, right, of the patient, of the adolescent with non-alcoholic fatty liver disease. Make this sort of like a family effort so that the entire family's on board with the dietary pattern that the adolescent's been assigned to. We'll deliver all the food to these families for the entire 12-week period, and then measure the liver fit outcomes using MRI to look at the liver before and after the intervention. And then also we're going to do some more metabolic testing using some different techniques like the euglycemic clamp to look at changes specifically in hepatic insulin sensitivity. So that, the liver is like a major regulator of, glucose metabolism. So really this idea that diet and using this family-based approach, we can potentially deplete liver fat to the degree where you can consider that the disease is completely reversed in these kids. So that's the current study we have going. We're going to look at some other more like specific pathways within the liver using some metabolomics data and that sort of thing. So we're really excited. We're just getting that study off the ground and recruiting families for that now.
Great. I have a follow-up for that, but before we get to that, I want to ask Dr. Stine about something specific. You said in your introduction or your summary of some of the research you're doing, you used two different phrases. One, you talked about how if you place individuals into environments, that they tend to be healthier, and that speaks to a lot of systemic inequalities we have. It speaks to structural needs for physical infrastructure, for safe environments, et cetera. But then you also spoke to the individual nature of people making good decisions, and some of your about prescribing basically exercise, if you will, which is a more individuated sort of instance. Can you talk about your research about kind of the notion of exercise doses for fatty liver disease and what a practical takeaway might be for our audience?
Yeah, thanks for that, question and summary, Jeff. And, a lot of, supporting folks goes back to understanding human behavior, right? Every person is different. Everybody has different motivators and barriers. So how do we, make a sweeping consensus statement, which is then going to allow the individual to be successful? So, that's kind of the framework behind our research. And, I think about exercise, almost like a medicine, so as a physician, prescribe a medicine, with an intended result. So let's take type 2 diabetes, for example, since, Dr. Goss does work in this field. If I want to prescribe somebody a medication, let's choose metformin. I have them take one pill twice a day at a strength of 500 milligrams. They're then going to take this for 3 months, and then we're going to repeat, a marker of their blood sugar control with a hemoglobin A1C to measure the outcome. So same thing with exercise, right? We talk about, frequency. So how often, should somebody do this? We talk about intensity or how hard, the type of exercise you can vary, and then you have the time. And when you put all this, together, you can arrive at this dose of delivered exercise. And it's important because every day is different, right? Some days, I may have time to go ride my bike, for an hour. I did Peloton this morning, when it was dark early. But tomorrow I know I'm on call, so I'm just not going to have that same amount of time. So being able to vary these individual components to get to that dose of exercise delivered, really we think should help reinforce and support people in achieving their goals. Now, that hasn't been proven just yet from a scientific standpoint, but if you extrapolate from other fields, certainly we would expect this to fall in line. So. You asked me what dose should somebody, do, I believe. So, in terms of how much exercise or activity, there's no one optimal amount at this point. Based on some of our work, as well as, indirect comparisons from others, we do think people need to do, at least 750 metabolic equivalents of task minutes of activity per week. And you may say, well, what the heck is a MET minute per week? Right. And that's what the average person or most people will say who don't, do research in this area. 750 MET minutes per week is about 150 minutes per week of brisk walking. So, we're not telling our patients to go to a marathon or a triathlon or even go to the gym. It's simply, walking at a modest pace is enough to help improve their fatty liver disease.
So it's movement, essentially, in that regard. I think one of the big hindrances that people run into is thinking, wow, I need to, quote unquote, lose weight. So I have to go sign up for a 10K or do some sort of high intensity program or something like that. But really what it seems like you're saying is that we need to motivate people, or we need to be able to support people in terms of basic movement, walking, movement, swimming, dancing, whatever it is. It's not necessarily go and crank out a bunch of deadlifts.
Yeah, really any movement is good. And over time, we're just reinforcing, healthy behaviors. I would say, most, folks in this area probably agree a combination of aerobic-based, activity, walking, jogging, light cycling, plus, some resistance training with even, body weight exercises, household items, picking up some milk jugs, doing bicep curls, 2 days a week, in addition to, meeting that activity goal for your aerobic exercise of 150 minutes per week of moderate intensity activity. Would be sufficient in order to help improve this condition. But again, it's a process, right? Rome wasn't built in a day. People don't go from being, sedentary to, achieving their activity goals in a day or even a month. It takes many, many months of support and having a team to help you through this.
Yeah, absolutely. Absolutely. Now, Dr. Goss, I want to come back to you with a question based on what you, just out of curiosity, what you had said earlier about your program. And you talk about whole foods. We've talked about, diet quality a little bit. You talk about kind of buying the groceries for the family. So in a pediatric environment, so we know the environment, much like we were talking with Dr. Stine, can really impact how the individual eats as well. I'm wondering if you could talk a little bit about this notion of whole foods versus processed foods. I've seen NASH patients, for instance, not really understand the distinction and feel like they can only eat fruits and vegetables, for instance, and they leave out major aspects of their diet in this. Where do processed foods come into play in terms of the nutrition for a patient with fatty liver disease or NASH?
Yeah, I guess like the way I think about processed foods is the way in which not all processed foods are going to be harmful or are going to negatively affect fatty liver disease, right? So it's the way in which these foods are affecting metabolism. It's what is the metabolic response to consuming a processed food, right? So a lot of processed foods are rapidly digested, and that's when we call them, they have a high glycemic index, meaning they're rapidly digested. Glucose skyrockets, insulin secreted in high levels. This is all stimulating lipogenesis, right? This is all affecting the liver in a way that is sort of pushing it towards depositing lipid in the liver, causing liver fat, versus enabling the liver to oxidize fat or mobilize fat and burn fat. So it's sort of looking at foods in a way more from a metabolic standpoint. Like, it's less about how the food is processed and packaged. It's more about the way in which the body is digesting it and seeing it metabolically, right? So I mean, we don't exclusively include just all whole foods that have, haven't ever been in a can or anything like that. It's more about thinking about how these foods are in fact affecting metabolism. A lot of times, 9 times out of 10, the ultra processed food category are going to be very highly glycemic, which could be problematic for a liver patient. So something else I didn't mention this about our study too, is that a lot of times when it comes to liver fat, individuals assume that weight loss is necessary to improve fatty liver. In our studies, we give a weight maintaining diet. So we don't ask our patients to intentionally calorically restrict. We provide an energy level that will help a patient maintain their body weight. It truly is, in the absence of weight loss, we can see depletion of liver fat by just manipulating the way in which the liver is metabolizing these nutrients. And again, it goes back to, the metabolic environment. Is the liver burning fat, or is the liver storing fat? And how are nutrients affecting hormones to manipulate that very factor? So this can all be done in the absence of weight loss, which I think is an important point, because even in an adolescent population, sometimes weight loss might not be necessary or might not be advisable for a developing child or a developing adolescent that may not even be, what you would consider have obesity, but yet they still have developed fatty liver, which, obviously diet and sedentary behaviors can contribute to. Having an adolescent in a study where you don't have to tell them they have to restrict what they eat, they just have to change the types of foods they're eating, is a very powerful thing for the parents and for the kids to not focus on body weight at all, but really just say, we're eating this way to improve your metabolic health. And that's going to improve your long-term health outcomes. It has nothing to do with your body weight.
This is fascinating. I could go a bunch of different places with this. I mean, obviously there is a lot of implication for NASH and lean individuals for this sort of approach as well. Mm-hmm. But I'm curious, I mean, the conventional wisdom, which I think is fairly supported by the data that exists right now, the evidence base, is that for metabolic, for facing a metabolic disorder, patients are really often given broad advice that to impact NAFLD and NASH, you need to lose 7 to 10% of body weight, which really doesn't take into account like lean muscle mass. It's kind of another way of saying you need to lose 7 to 10% of fat on your body. I'm curious if by switching up the diet in the way that you're saying, you don't have as much of an emphasis on weight loss as you do on the fuel that is going into the body, if you will, at that time. Is there a hypothesis? Is there a thought that weight loss is then a consequence or a side effect of that?
Yeah, that's a great point. The way we kind of think of it in our lab is like, you have to fix the metabolism first. And then, like you said, like weight loss is sort of a side effect of that, right? So when you're not doing intentional caloric restriction, when weight loss is not the target, it can be very empowering for the patients. And it helps with like body acceptance and body positivity to think of it that way, right? So, but yeah, that's a really great point. Once you sort of change all these metabolic processes, weight loss will happen. It can happen, right?
Right.
But it's very different if that's not the primary outcome. Like if the primary outcome is to improve your NAFLD or whatever underlying condition that it is that you are trying to treat with nutrition. That's a great point. Absolutely.
let me come back to you, Dr. Stine, on this as well. When we're thinking about this 7 to 10%, body weight that people have generally spoken about as well, is that loss of body weight? Is that something that you would agree with as well, or is that something that there needs to be kind of a little different emphasis on as you deal with individual patients?
Yeah, I think that goes back to a lot of the key things that Dr. Goss and you were discussing. And historically, we have viewed lifestyle change with dietary change and increased activity as a vehicle for weight loss. 7 to 10%, for individuals who are overweight or obese, and then less weight if you are normal body weight, only 3 to 5%. Mm-hmm. However, similar to the nutritional research field, the exercise research field is actually showing many more weight neutral benefits as well. So even independent of losing either one of these weight loss goals, depending on your BMI, we know that physical activity will reduce liver fat. Okay, it's going to improve physical fitness, which will actually improve overall mortality. So if you increase your fitness 10%, you will actually improve your overall mortality by 15%. Over several years. It's going to improve your body composition depending on the type of exercise you do. You're going to reduce visceral or subcutaneous adipose tissue, increase your skeletal muscle mass. You're going to improve your vascular biology. Your blood vessels will be less stiff. You're going to be less likely to develop blood clots. All these things happen independent of weight loss. Now, if you want to reverse NAFLD and NASH and improve the liver histology under the microscope, at this point in time, we do still think weight loss is necessary in order to do that. With that said, we have some emerging data which may begin to suggest that our weight loss targets may perhaps be even a little less than what is currently accepted, but more to come on that in the upcoming year or two.
Yeah. Okay. We have a few minutes left here, and so I want to turn to kind of practical suggestions, and we've talked about that a little bit with each of you on this as well. Dr. Goss, based on the research and kind of everything that you've seen, do you have any practical recommendations for our audience to turn kind of a liver healthy diet from a hill to surmount, a chore of some sort, into something that's more attainable for folks that are busy and managing life, kids, jobs, all sorts of things? What are two things you would recommend for liver patients from a nutrition standpoint?
Sure. I mean, I think like a really good place to start is really being cautious of the amount of added sugar and avoiding sugar sweetened beverages in the diet is like it's like the low hanging fruit of what the first step should be to like watch out for liver fat in terms of nutrition. And then like we've also talked about is this ultra processed food. If you're focusing the majority of your diet coming from whole foods, like whole fruits and vegetables, whole foods like that versus what you would find in the center aisles of the grocery store, what we would consider like highly processed. Making simple changes like that, I think can have a really, really profound impact on liver health and liver fat deposition in NAFLD patients. So obviously there's some good places to start.
Yeah, excellent. That's consistent with everything I've heard as well. If you can pick one thing to zero out, it's those, sugary beverages, and then start adding, healthy whole foods in. And it's really interesting to hear that in the context of your kind of weight neutral approach as well, because you are definitely taking something that is damaging away, but adding something interesting that might be, a puzzle to fulfill. How can you integrate this or that into the diet?
Right. And some of our studies, I mean, we sort of went down this path of looking at NAFLD, doing studies in other patient populations that were weight neutral or weight maintaining, right? So, we did a study in adults with overweight and obesity. We did a study in women with PCOS that also had obesity, where we fed them these, like I was mentioning, the low glycemic, moderately carbohydrate restricted diet versus a high glycemic diet at a weight maintaining level. And what we found was this sort of selective depletion of visceral adiposity, of intermuscular adipose tissue. So these adipose tissue depots that were quote unquote metabolically harmful versus what's thought of as like metabolically benign, which is subcutaneous adipose tissue, particularly in the thigh and the hip region. So again, without weight loss, we were seeing this sort of like remodeling of fat distribution to a healthy, metabolically healthy pattern. And so sort of using that data, we branched off into the NAFLD area because fatty liver is really considered like an ectopic lipid depot, right? It's one that can be metabolically harmful. Could we still get those same results? Depletion of that lipid in the absence of weight loss. So that's sort of how our studies veered into fatty liver disease, but this sort of diet, thinking about metabolism and a healthy fat distribution, applies to a number of different patient populations that deal with chronic metabolic diseases.
So I'm going to flip the script here a little bit for you, Dr. Stine. I know your field isn't necessarily in pediatrics, but you've spoken to some stuff that I think has a real implication there. So let's see how this question goes. It's NASH and NAFLD are often considered kind of an issue for adults. But, we have seen this troubling rise, as Dr. Goss has mentioned, in the pediatric space, which is in parallel with rising obesity and type 2 diabetes. We've got upwards of 10% of American children have developed fatty liver disease now. And you've spoken to a process that's really interesting about kind of systemic and environment versus individual. And I feel like there's no better place to implement that than parents for their children. If you were to have any recommendations, how could the adults in a child's life, their parents, their guardians, their teachers, whatever, nurture an environment that helps promote liver health or prevent fatty liver disease?
Yeah, so Jeff, thanks for that question. Again, full disclosure, not a pediatric hepatologist by any means, but I'm a father and somebody who, on a personal level, values being physically active as a family. And professionally, when I talk to people, I'm helping them undo 20, 30, 40, 50 years of behavioral choices. And, doing something new as an adult, it's scary. It's hard. The older we get, the less opportunity we have to do new things, to, make changes, to undo years and years of programming. So, starting when, people are young and malleable and really helping them is paramount to solving this issue. Not just non-alcoholic fatty liver disease, but obesity, type 2 diabetes, every type of metabolic disease, and even medicine in general. We are so focused on reaction and disease rather than prevention and health, right? We call it healthcare, but in my opinion, it's really disease care. It's not really healthcare. So that takes a societal buy-in, that takes parental buy-in. And, to leverage some stuff with the pandemic, right now we have the Great Awakening. People are realizing that, as parents and adults, that, perhaps the current infrastructure of the way, jobs are set up is not conducive to leading a healthy lifestyle. And then you don't have the time or the energy to then devote that, to your kids to help reinforce these things. But, again, getting, calorically dense foods, fructose-rich beverages with, sodas, pops, juices out of the schools, removing vending machines, making sure, recess is prioritized, allowing equitable access to parks and infrastructure. These are questions well above the research level, the clinician level, GLI. I mean, it's a global, issue here, and, engaging all the stakeholders, getting people to buy in is necessary. But on a completely individual level, you have to be committed. Pick one or two activities that you enjoy doing with your kids. Try to get them active. My kids enjoy being on the screen as much as the next kid. They love Nintendo, but setting screen limits is important, and just prioritizing some sort of physical activity as a family can help reinforce these behaviors when your children are young.
So it's been tough days here for a couple of years, with the pandemic. We've got stuff going on in Ukraine. There's been recent shootings and what. We've got some pretty sobering statistics around fatty liver disease and NASH as well. But we do have International NASH Day, which always, for me, provides this like daylight of hope for bringing everybody together to be able to talk about how we address this epidemic disease each year. And so as we approach International NASH Day next Thursday, I guess a week from tomorrow, actually, I want each of you to talk. Let's do a little more of a positive spin right now. Are there things on the horizon in your field or research that you're looking forward to of some sort? What has you looking up these days? Dr. Goss?
Sure. I mean, I think I've been really impressed about the level of interest and a number of research dollars that are being devoted to figuring out, fixes to this. I think there's just a lot of interest. And I think, there's growing interest in really identifying strategies. Obviously, like we said, there's no drug or device that can reverse fatty liver, right? So we were relying on lifestyle factors. And I think people are becoming more aware of that. And it's just, I think there's a lot of positivity in that, that we can all work together to sort of figure out how to address this problem.
Okay, Dr. Stine, what's looking up for you?
Yeah, I just would say, human resourcefulness, right? The past 2 to 3 years have been incredibly difficult for everybody. People have found new ways to, reinvent themselves and find ways to get by and have non-traditional ways to lead healthy behaviors. So seeing human ingenuity, it gives me some hope, with that. And, again, like what Dr. Goss was saying, that there's more focus, more research dollars going towards infrastructure. Events like this, continue this conversation forward and broadcast this and get the message out. So I think continued advocacy, the devotion towards that, I really appreciate GLI's commitment. And, these two things really have me, positive and hopeful for the future.
Excellent. Lots of good work to be done here. I'm going to say one last thing about what's got me looking up real quick, if I may, which is that we received word over the past couple of days that one of the close friends of the Global Liver Institute actually got the phone call and received her liver transplant yesterday after too long of waiting for it. And the first thing that this person did on social media was send out a thank you and asked all the friends and family and all of her supporters to remember the transplant family. And I just think it really speaks to the character of that person. And this is a great positive voice for liver patients and someone who we all care for and send good vibes to, thoughts and prayers, and remember in the hard work that we do. And so we're thrilled to see the transplant go through, and we hope for good days ahead. Final thing, let me ask for you guys that are doing the research, are you on social media? Or if someone is wanting to find out more about the work you're doing, where do they go to? Dr. Goss, where would they find more about the work you're working on?
Sure. I try to share everything regularly on Twitter. So you can find me on Twitter. And I have an Instagram account if you want to look there. I try to post like study recruitment updates and new study funding things, opportunities that we have too. So that's a good place to start, I suppose.
Excellent. Dr. Stine, where can folks find you?
Yep. Yeah. Follow me on Twitter at Jonathan Stine, MD. Feel free to email me. jgs178@psu.edu. Also, we have a Penn State Liver Center webpage, research.med.psu.edu/liver, and always happy to continue the conversation forward. Thank you for having me today.
Awesome. Check out the Global Liver Institute across all the socials, certainly as well. That's Facebook, Instagram, Twitter, LinkedIn. I don't think we're on Reddit yet, but we're across all the socials as well. And of course, find us at globalliver.org. And don't forget about the wealth of content, screening, educational materials, and expert panels. I mean, we're going to be looking at better diagnostics, leading models of care, perspectives from Black pediatric patients and their families, and of course, hearing from NASH patients in their own voices as well. I want to thank you both for joining us today. To our audience, be sure to register to attend International NASH Day next Thursday. You can check it out at internationalnashday.com. There's some hyphens in there in between those words, or just go to globalliver.org and you'll be able to link into that as well. And you'll be able to find out if there are any community organizations holding events in your area. In the meantime, standing in for Donna Cryer, I'm Jeff McIntyre, and until next time, be well.
Please be sure to like this video, subscribe, and share your thoughts and suggestions in the comments below. Join us weekly on Wednesdays at noon Eastern Time for more episodes of GLI Live. Check out our website, globalliver.org, and follow us on social media to learn more about the Global Liver Institute and stay up to date with the latest in liver health. Until next time, stay safe, stay well, and stay connected.